This is a talk I gave. I gave a talk on pharmacogenomics, I think a couple of years ago now, and so really wanted to update everyone on the exciting developments that have happened since then. And so, first part of this talk is a little bit of a revision about that, and some of the background, and then some description of the things that have happened. In the medical school and in NHS Tayside as a consequence of that work and where it's going. I always start off my slides on precision medicine with this one because it really does summarize the problem or the challenge. In other words, from the left to the right, you're starting with entities that we know about and we're very sure about, shapes of the patients, if you like, that we manage. And then really what is happening as we get more information about patients and individual patients, we're starting to treat them more and more and more as individuals. And that is much better for patients, much safer for patients, but also it represents some challenges for the way we treat patients because of obviously there's much more nuances there. And so a little bit about the background. My lights go off automatically in this room. So a little bit about the background is this is one of the essences of the problem as aging populations across healthcare systems, many more long-term conditions, more drugs, and then much more opportunity for unwanted side effects and causing harm. And so there's this sort of circle between polypharmacy and multimorbidity. And a lot of healthcare organizations are trying to break this harmful cycle. This is some data from a long time ago now, but it's still relevant. As that happens and we prescribe more drugs, there are more unforeseen adverse effects of drugs, but whereas medication errors are sort of staying largely flat. And so this is a major problem for healthcare organizations. And this is a great slide from my erstwhile colleague, Professor MacDonald, but essentially some people respond very well to drugs and they get a great deal of benefit for it. I don't know, can you see maybe you can't see my pointer if I use a laser point, maybe that works there. So some people get a great deal of benefit from, but some people get no benefit from the medications that they take. And quite about a third of people in the middle get moderate benefit, but it's these people who get no benefit when we prescribe them drugs who are exposed to all the risk that the drugs mean in terms of them taking it. And it's really trying to prevent this harm that's one of the biggest challenges that we have. So what has become very apparent over the past few years is that the common genetic variation that we all carry that has no other implications other than just the variation that we see between us is a major determinant of how individuals respond to medications. And there are a number of organizations across the world, and we're developing this in the UK as well, for looking at the genetic variation and how that affects how we treat patients. And there are an increasing number of clinical guidelines that have been produced by these organizations. And this is very much an evidence-based, formal evidence-based approach with all the same standards of evidence that are applied to all other treatments and interventions. And so these evidence guidelines are available. And at the same time, our ability to obtain this information is getting better and better and quicker and cheaper and cheaper. So many genotyping experiments that have been, or genotyping that's been done in the past over years ago was obtaining single genes for individuals. So when you request conventionally to a genomics laboratory in the past for a genetic test to be done, it was largely this approach that would have taken place. And you're able to detect the rare variants that we're interested in for most of medicine, copy number repeats, etc. But it's been this that has resulted in the main explosion of genetics, which is the ability to detect common variants in 20 million if by the time we impute across a human's genome. So 20 million places where you potentially differ from the person sitting next to you. And then, of course, there's a whole genome sequencing which obtains the 3 billion base pairs for the entire human genome for every single individual. And of course, then you manage to get all of these single nucleotide polymorphisms, as well as all the rare variants as well. So there's been this movement across the past 20 years or so in terms of getting more and more dense genetic information. And I guess one of the biggest problems, the biggest headaches for everyone is how you handle and manage such huge volumes of data obtained from an individual, especially if you're going to use it for healthcare when you're not specifically looking for one particular variant. And this is the other major thing that's happening, as I said earlier. This is essentially the cost of a whole genome sequence is very, very cheap now. Cost of a single CT scan to the NHS, for example, and doing whole genome genotyping with all of those genetic variants, the 20 million genetic variants, is less than the cost now to a healthcare organization of a single chest X-ray. And of course, that only has to be done once in a patient's lifetime. So this means that this information can be obtained extremely cheaply. And we really have segued now from whether we should do genomic medicine to how we should do genomic medicine, because there are so many ways that the genome can be used to enhance the quality and safety of patient care. And of course, this is what we're trying to do. This is patient population full of a mixture of different types of people that we manage in the clinic, all sorts of different types of people. And the standard approach is that we just take them pretty much as they come, and we give them a particular treatment. So this might be all hypertensive patients, for example, and we have an algorithm for treating them with a specific kind of drug. And we know that a significant proportion of those, as I was saying earlier, won't get any benefit. And of course, that results in polypharmacy and potential harm. And by using information better, particularly information in the genome, we can optimize prescribing so that certain people get the right drug. And that's the essence of it. So a couple of big things have happened since I last spoke. And one of these has been this document that has come out from the Royal College of Physicians and the British Pharmacological Society, published in 2022. And I recommend people read this because there's some very, very great cartoons and it makes things really easy to read. But they have essentially called for now applying or implementing pharmacogenomics in routine healthcare to improve outcomes and safety. And this has just been published in Scotland. This is the Scotland Genomic Medicine Strategy for the next 5 years. And one of the main things that it incorporates is pharmacogenomics as a part of that strategy. So it's happening, and the world is changing, and healthcare is changing as a consequence of this knowledge basis now, and also the cost effectiveness and the fact that it can be done in very, very low technology or very well established technologies. So one of the main paradigms, the sort of no-brainer that everyone quotes, is clopidogrel. It's all clinical guidelines for stroke in the UK recommend clopidogrel monotherapy largely, although we do use dual antiplatelet therapy more frequently now, following a non-cardioembolic ischemic stroke. It's a prodrug. It requires metabolism, and about 25 to 30% of patients carry a common genotype that means they're less able to metabolize clopidogrel, and therefore, when they get clopidogrel, they aren't essentially getting the critical antiplatelet that they require to prevent further events. And since 2010, the FDA put a boxed warning on clopidogrel because we've known about this since then. And this is some research that we did at the university here, and it showed that patients with stroke have this very high hazard ratio if there's a slow metabolizer, and metabolism is based on CYP2C19 genotype. And we meta-analyzed with some other data. Now, one of the things that we have at the University of Dundee is very large bases and also bioresources. And this is Professor Colin Palmer, who runs the GoShare bioresource. And one of the things that I was aware of a number of years ago was that we had genetic information sitting in this bioresource. And so why not use that genetic information if it existed for a patient? Because about 1 in 10 patients of the population in our region have this pre-existing genotyping. And I wanted to use it, and I coined this term that has been coined previously, predictive, prevented, personalized, and participatory P4. And I call this initiative P for Me. And what we did was we got permission to get this genetic information. And if a patient was in the hospital, we could use that to give them the right drug. We got some innovation funding to do that. And this was really an infrastructure for spearheading the delivery of pharmacogenomics in our hospital. And this is essentially how it's done. Here is a patient who needs to be given clopidogrel, and you can do the genetics and find people who are normal or rapid metabolizers based on their genotype, and you can find people who are poor metabolizers or intermediate metabolizers and offer them an alternative antiplatelet drug based on existing guidelines from these organizations. And what we did with that was we then got, because that was successful, we got some pump priming funding through the Tayside Innovation Fund, which enabled us to genotype everybody that came through the hospital, because obviously 1 in 10 individuals couldn't have the benefit of getting prescribed the right antiplatelet because they hadn't taken part in SHARE. So we got funding to be able to essentially do this for everyone. And we monitored the effectiveness of switching that over a period of time. That involved setting up an ICE request, and here is the request on ICE for people that have used it, and worked with colleagues in the genotyping laboratory, particularly David Beatty and his team to do this. And David Beatty's team set up an assay, and here is an example of the assay where we're able to genotype people on a plate using this TACMAN approach to be able to separate people into different genotypes to be able to get what their genotype was and produce a report. So this is a report that got sent out and in fact goes into a patient's medical record, and you can see that this patient here was adjudicated as having impaired clopidogrel metabolism, and an alternative antiplatelet should be selected in this case. And there's more details of the genotype there. And that's a kind of complicated report. So we developed this straightforward letter that went straight out to GPs from the acute stroke unit. And it just simply explains that this patient may be have reduced effectiveness based on their genotype, and they should be prescribed this alternative medication, which in this case is aspirin and dipridamole. And so that was a very successful program. We got funding for a year, and we found that 28% of the patient population were these slow metabolizers, and a large number of those, 83%, got switched to other medication. The reason why some people weren't switched was because their diagnosis changed, or they turned out to have atrial fibrillation, for example, or they didn't survive, or 1 or 2 other reasons. But a very high number got switched to alternative medication. And there's some interesting comparisons here with the rest of the UK in terms of frequencies. So the intermediate metabolizers was slightly higher in the rest of the UK, and that's probably due to greater ethnic diversity. People from Southeast Asia have much higher frequency of these variants, for example. So as a result of that success, and we were able to use predicted number needed to treat for switching to estimate that we had prevented 17 major adverse cardiovascular events in Tayside as a consequence of that switching process. And so we were the first health board in the UK to offer genotype guided treatment for stroke patients, and indeed for a common drug and for a common genetic variant. And what happened next was we had some other interest from other prescribers, and in particular from colleagues in infectious diseases and respiratory, for genotyping patients who might need voriconazole, which is also metabolized down this same route. And of course, patients like this a lot, and it gives prescribers and patients a lot of confidence that they're getting the right drug, the right time to the right patient, and making patients more safe. And this is Alex Matos, who presented this nationally and won an award for because Alex was a fundamental component of the success of the pilot. And here is the rest of the team. Here's Alex, and here's David Beatty, and this is Matthew Beanie, who set up the genotyping setup to be able to get this done. And here is our first patient, Mr. Anderson, who benefited from this new pathway, and he was delighted that his drugs were safer and better. Our genomics education, the genomics education program in the UK is now using this as an example, the NHS Tayside experience as an example. And of course, this is generating knowledge for more widespread, realistic use of pharmacogenomics. And here is the stroke team, who are, of course, the team that bore the brunt of it. There's one or two of the team missing from this picture, but the success of this was very much down to their taking this on board and implementing it as part of their clinical pathway. So it was a great success, and the pilot then went on to become business as usual. So this is now full-time part of the clinical pathway for patients with stroke in NHS Tayside. And what's happening in about a month's time is that NICE are going to produce the guidance for genotype testing to guide clopidogrel use after ischemic stroke for transient ischemic attack. And the work that we did in NHS Tayside was very much part and considered as part of developing this guidance. And I sat on this committee for this. And the NHS Tayside use case will be published alongside with this in July. So this is the first guidance from NICE for a pharmacogenomic test for a commonly prescribed medication. And of course, NHS Tayside is now ahead of the game on that. What has happened since August of last year was we submitted this to the Scottish Government's Accelerated National Innovation Adoption Pathway, and it was accepted. So this is now being rolled out. The NHS Tayside approach is now being developed for rollout across the rest of Scotland, where we anticipate we'll probably be able to prevent up to 200 major adverse cardiovascular events and strokes per year. And the Tayside Genomics Lab and also the Glasgow Genomics Lab are going to be the two main centres for that. So Scotland will essentially be leading the way on innovative health care on a national scale through this program. So it's exciting because that really does herald the beginning of a new way of implementing genetic medicine in everyday clinical care, and it's a departure for genomics laboratories who've been much more set up for doing rare genetic variants. So it's going to change the paradigm of working in NHS genomics laboratories. So what was also going on in the background all of this time was that the Scottish Government commissioned the Living Labs in Glasgow to tender to industry to deliver a national pharmacogenomic solution for the whole of Scotland. So this was a big commissioning process from the Scottish government, and it was largely targeted for the population of Glasgow, but with the idea that that would roll out to the rest of Scotland. And Memo Research and a company called MyDNA, who make clinical decision support. You'll hear a bit more about that in a minute. And Illumina, who do a lot of the, or almost all of the big genotyping for the NHS in the UK, and partnered with us on that. And so we had a consortium, University of Dundee, NHS Tayside, MyDNA and Illumina, and we won that. It's a long story, but we won that bid, and we were going to go forward to do that. I say were because very sadly and somewhat predictably, eventually the bid had to be withdrawn for some very good reasons, really, but it didn't go ahead. One of the main reasons, amongst others, was the publication of the PREPARE trial, which was in the Lancet in 2023, which was essentially doing what was being proposed by the bidders for the tender, which was to do panel-based testing to prevent adverse drug reactions. So this was a large multinational study, including the UK and all sorts of healthcare environments, and it genotyped people across a number of variants associated with drug response. And even though it was open label, there was this large drop of about 30% of adverse drug reactions, and it was widely promulgated, obviously. And this, together with evidence, as I say, the CPIC guidelines are all about evidence from randomized trials, largely for various single drug gene combinations, like clopidogrel, for example. But this was the first time a panel-based testing had been done. And there are some questions about this trial, but it was it certainly showed that you could reduce harm in this way, doing panel-based testing. So there was some questions about whether or not we needed to generate more evidence. One of the other things that was clear was that trying to make such a huge intervention across Scotland, or come up with a solution for a huge intervention across Scotland, was very, very complicated. It was big and extremely hard to tackle. And as the work was done by me and others to try to demonstrate how we would build this solution, it became increasingly clear that it was going to cost very, very much more than any industry consortium was prepared to pay. And so there was this concept. I don't like this idea of eating an elephant because I rather like elephants being alive, but to tackle things one bite at a time. And it just so happens that that's really the approach that we had been taking in Tayside, because what we had found with our single drug gene intervention using clopidogrel, looking at some single SNPs, that there was an increase in interest from other services. Vascular surgery have expressed an interest in doing that, and we were talking to cardiology as well. And but also, as I mentioned, there are other drugs that can be metabolized down CYP2C19. There's definite enthusiasm for looking at those drugs as well in clinical practice in Tayside. And we're already doing this for voriconazole. And we had always, David Beatty, myself and others, we'd always thought about looking at other main pathways as well. So we set up this pharmacogenomics informed medicines management in NHS Tayside because this is a much more organic, incremental approach. In other words, you start a wedge with clopidogrel, and gradually, as you develop more awareness and training and understanding, you build to other drugs, other genes. And again, we're partnering with industry partners to provide the infrastructure for that, including the costs to the genomics laboratories for doing the genotyping. So just by way of example, from from MyDNA. MyDNA is an Australian company who have a lot of experience for doing clinical decision support. Any clopidogrel is fairly straightforward because it's a couple of genes, gene variants, and one drug, and the decision is very clear about what you should do with that piece of information, particularly in the context of stroke. But when you have a larger number of drugs and genetic variants, you need some kind of decision support, because no human being, or at least I certainly wouldn't be able to do it, and can hold all of that information in your head for all the sort of complicated drug-drug interactions as well as drug-gene interactions. So here's a sort of example. Here is a woman who is diagnosed with major depression, but she also has hyperlipidemia and is taking atorvastatin, and that's also affected by a particular genetic variant that's commonly carried, SLCO1B1. And she also is taking a proton pump inhibitor, which is also a CYP2C19 substrate. So both of these, she might have genetic information about that might alter her treatment. And because of her depression, she's been initiated on escitalopram. And the dose is increased. But after a while of using this, she still has mood, slight improved mood, but difficulties in falling asleep and agitation and nausea. And the decision support that's available from MyDNA, for example, is able to identify that she has this genetic variant from data from the laboratory, and provide in simple recommendations to the clinician, alternative approach to managing her depression, and some other information around that. And it gives an idea of the strength of the information that's available based on clinical evidence. So in this case, this patient could be switched to an antidepressant, an SSRI that wasn't metabolized by CYP2DD6 or CYP2C19, and things were better. So this is the kind of clinical decision support that's available. And I know that most of you who are watching this are thinking, oh, holy cow, how would any prescriber ever be able to read all of that and do all of that in the microseconds that we have with each patient to be able to make clinical decisions? And of course, this is a major aspect of what it is that we are trying to work with in order to enhance things in what it is that we're doing. So we have implemented this framework, which is actually very similar to this framework which is published here, in terms of an overarching way of making this work in this healthcare organization, but this will be part of the rollout to other parts of Scotland as we progress with this initiative. So first of all, you have to have an overarching group that carries this forward. And then there's a whole lot of governance. So particularly with the clopidogrel, we had to step through a lot of hoops that I described previously in terms of medicines advisory group locally and the formulary and so on. So everything was agreed by the organization and indemnified by the organization for the clinical decision support that you're making down each pathway. Obviously, there's some laboratory results that need to be standardized, and David Beatty and his lab have been working very hard on that standardization and governance approach. Clinical people need to be involved in this, because how they would work with this in terms of their practice and for carrying these things forward. And so there's a lot of work that needs to be done there. We need to educate. Partly that's what this Grand Rounds is for, to let people know about this and promote and have people understand how genomic medicine will influence their practice and why that's important, etc. Now, one of the main things is this clinical decision support and electronic health record implementation. And it's very clear, as we've been doing pharmacogenomics and implementing pharmacogenomics, that this is the major thing. Doing genotyping is straightforward. The technology is very straightforward, but decision support and incorporation into the electronic health record is hard. And it's one of the things that we're working very hard with our colleagues in digital health in NHS Tayside and others you'll see a bit later in order to absolutely enhance the ability using clinical decision support in the electronic systems that we have to enhance the ability of prescribers to make the right decision at the right time with the right information in a way that doesn't clutter up and impede their ability to manage patients. So that's essentially the main elements of what we're trying to build with some of the funding that we're pulling in to do this together with our industrial partners to be able to provide this for NHS Tayside. So a centralized genomic repository where all the data goes, but we only pull down some of that into electronic medical records. We need to think about how that goes into medical records and who knows that it's there. And we're working with the providers of vision software, which is ubiquitous or will be ubiquitous across Scotland, as well as the secondary care providing system. And that means prescribers can make right decisions and ultimately patients will be able to know why those decisions are being made. One of the main things that we need to concentrate on to develop this and make it grow is that we need to be able to evidence what it is that we're doing and to show that we're having an impact and that we're not just spinning like tops doing busy things that doesn't actually affect patient care. So we need to generate evidence of effectiveness through learning healthcare system approaches. This means pulling things into data centers for us to be able to interrogate that and produce output in a way that allows us to generate evidence, as I say. And that's a fundamental component of everything that we are building to make this happen. So I'm going to tell you now about the next stage of things. So we've been joined by Dr. Andrew Radley, who's just recently joined the medical school, who's working with this program and has been very successful in working with the Angus Strategic Planning Group, who provided us with the first tranche of money to implement panel-based testing in Angus practices. And so they're going to be the test bed where we engage clinicians and patients and we look at different ways of providing the data and delivering benefit to patients across this program. And phase one of this is going to be very simple. We've adopted just a few drugs because remember, we're going to eat the elephant in chunks and not try and do everything all at once. So we're choosing a small number of drugs in the first instance. And the first one is going to be statins. And we're going to get people working with us on that and taking blood from these individuals as they come into the for medication reviews in practice. And these are in 2 practices in Angus. And we're going to understand how we do that and how that works. So something very tractable in a very small way, first of all. And we will also mobilize, as we did for the clopidogrel thing, if you remember right from the beginning of this talk, we used SHARE to be able to have pre-existing genotyping. So we're going to make use of SHARE to identify patients prescribed statins and other drugs, opiates and SSRIs, not clopidogrel actually. And so we'll be able to have pre-existing genotyping, and this will allow pharmacists in the practices in Angus to be able to practice working with patients to exchange information and modify their treatments based on this. And that will allow a language to be developed and an interaction to be developed and to for people to get experience with this process. So as I say, very, very similar to how clopidogrel was first introduced. And that will allow the preemptive testing, in other words, pre-existing genotyping, which in many years from now, maybe 10 years from now, almost all patients will have pre-existing genotyping available because it will be part of everyday care. Simply by joining your GP, you'll have your whole genome sequence done. I know you don't believe me, but it's going to happen. And then in phase 2, what we will do is start to invite people that aren't in share and take more blood and review their prescribing and gradually build up. And once we've done this, we'll be able to roll out to other practices and start being more confident that we have a modus operandi for being able to do this in a way that's practical and realistic for both patients and prescribers in general practice. So first 2 practices, then 4 practices. So, there's a lot to understand about the barriers and enablers of pharmacogenomic testing in primary care. And there's, this is something that we'll be contributing to in understanding how to do this, because if we're going to make things better for patients, make things safer for patients, we need to be able to do it in a way that is acceptable to everyone involved. And as I say, most of this is about getting the information right and the information transfer right. So here are some of the research questions that we'll be addressing. What are the changes to prescribing associated with using the pharmacogenomics informed medicines management pathway? How do healthcare professionals, patients, and public perceive the acceptability and utility of this pathway in primary care? And what are the costs and benefits of this pathway? And how can these contribute to modeling the economic benefit for implementation across Scotland? So it's very widely agreed that what we are doing in Tayside, just as the clopidogrel pathway did, will inform on this process for transferring this to the rest of Scotland. And of course, there's a whole bunch of stuff that needs to be spoken about. It's changing. It will change the way we think about medicines prescribing and ourselves and our patients in terms of their genetic information. And so there's a lot of discussion that needs to go on about that. Is there anything special about genetic information? Well, of course, yes, there is, when it affects your health, such as a rare genetic variant like familial hypercholesterolemia or cystic fibrosis, for example. But common genetic variation that has no implications at all, except for when you take a particular drug, is a very different kind of information. One of the things that we do with clopidogrel is we certainly don't take a genetic exceptional approach. We treat it just like any blood test, for instance, looking at your usinase to determine your kidney function before you're prescribed a DOAC, for example, to ensure that you're not giving someone a DOAC with very, very poor kidney function. So it's just checking a genetic variant that's relevant to clopidogrel. And there are these very much broader, wider. This is an extremely busy slide. It's really just here to show you that this is complicated, and for no other reason than being here. But there's a lot that we need to sort of start thinking about. And I think the SHARE program, when we think of altruism, reciprocity, and solidarity, the SHARE program of sharing your genetic information so that it's not just good for yourself, but also allows genetic research to take place, is an important part of this conversation, and an important part of how Scotland enjoins in the concept of improved healthcare, using genomics in particular. But safer drugs and better drugs isn't just relevant to genomics. Why did that flick across? There's a Scottish Government Safe Prescribing Initiative, which is run by Alpana Mayer, who is, and we're collaborating with this initiative, because if you already have a program of prescribing in primary care, which is all about making drugs safer and de-risking prescribing, particularly in the people with polypharmacy and multimorbidity, then putting in genomic information into that program to enhance that seems to be the obvious way. And this government program, known as iSympathy, is all about implementing that in primary care. And it so turns out that the practices that we're involved in Angus for the pilot of the pharmacogenomics initiative that I've just been talking about are the same practices that are working with the Scottish government on implementing the iSympathy program. And this is really seen as also being enhanced by pharmacogenomics. So this is a slide that came from Alpana Mayor, and it's just to say that we're not doing this in isolation. We're very much linking up with Scotland-wide drug prescribing safety initiatives and the same process for doing that. So one of the things that's happened, well, that's changing by itself, I apologize, but this is a particular screen grab for using vision to be able to take information from all sorts of different resources. And in this case, it's this polypharmacy guidance for realistic prescribing. But also we can take genetic information and have information provided by MyDNA based on that genetic information and incorporate that into vision, which means that prescribers will be able to work with these interfaces in a very streamlined way to be able to implement these changes. And the practices in Angus, as I say, are piloting this anyway, and they're all extremely enthusiastic about incorporating this into their workflows. So we're simply going to be piggybacking the genomic results into this, and that's going to be a very important part of the framework. So this is towards the summary. We're going to have a few minutes for hopefully there'll be some discussion, for some questions. So we're starting off with these 4 practices in Angus, and doing what we call PIM Tayside with everything that I've told you about in terms of with our industrial partners Illumina and MyDNA. Illumina are providing large amounts of money to David Beatty and that framework to be able to undertake the genotyping. And MyDNA are providing funding for developing the interface for clinical decision support. We're using Share as to augment that, and as I say, I think Share is a very important way of thinking about engaging the public in their health provision, and also enhancing research and evidence generation around health provision. And I think this is going to be a very good model for this program and for Scotland in general. I've mentioned iSympathy and these 12 practices, so we're going to be piggybacking on that, and eventually the expressed view of the initiative that we're developing in Tayside, and this is with great support from colleagues in management, Jessica Henderson in particular, and others, and great support from colleagues in digital health as well for developing this. The view is that once we've solved things in terms of how this works and streamlined things in these small practices, we will then roll that out across Tayside, and hopefully working with the Scottish Government, we will also submit that to an ANIA program in the future to be able to take the learning and experience from that across Scotland. We have formally paired with our colleague Sandosh Padmanabhan, Professor Padmanabhan in Glasgow, who also worked with us on the original PIM bid for the industrial consortium. And as you know, it crashed, and it crashed and burned because it had to be withdrawn. And so Sandosh came up with this very nice Phoenix motif and the concept of rising from the ashes of the failed or the withdrawn bid. And so we formally partnered with the University of Glasgow to create an advisory group, a network of excellence, really to drive this across the whole of Scotland, and to really carry the conversation to the government, but also to the genomics network, etc. So we're trying to ensure that whatever we develop here in NHS Tayside is relevant to the rest of Scotland. And really, this is the final slide. The concept being essentially we want to make things better for patients, ultimately safer, better prescribing, making things predictive, preventable, personalized and participatory, so that patients ultimately are more enfranchised in their own healthcare and engaged in their own healthcare, that people who prescribe medications have access to good quality information and mechanisms of providing patients with better information, and that broader, wider Scottish data held within safe haven environments is more mobilized for being able to, including genomic information, but other information as well, is more mobilized in this context. Okay, so that's all I have to say. Very happy to take any questions. I will close this down somehow like this, and try and come back into the meeting somehow. Stop share. There. So I'll go into chat. No questions in the chat.
Alex, can I ask a question?
Of course, yes.
Sorry, I couldn't find a thing to put my hand up. That was really interesting. It's quite impressive. We've been involved in implementing clinical decision support within the Sky Diabetes platform. And one of the challenges we find is maintaining its, as guidelines change, updating the advice. And I'm just wondering how you do that within your pathway. Is that all on the private company to maintain the advice contained within it? Or is that something that you guys have responsibility for?
Well, a super duper question, and obviously we're at the very early stages of implementing this. And as I indicated with that diagram, it does need an overarching governance infrastructure and informatics infrastructure, and that is going to be one of the issues that we need to address going forward, is that evidence will change and develop. And so although an individual's genome doesn't change and develop, clinical guidelines will. So there is going to have to be an overarching group that does that. And my DNA will be having to do that all the time, as well as in terms of what they deliver. So the extent to which they will do that versus what our local governance group will need to do is still up for discussion. One of the things we do need to do is, and we've been talking about this with some of the UK-wide network, and that is that the current guidelines, the CPIC and the Dutch Pharmacogenomic Working Group guidelines, are very much, for America and for Europe, and not necessarily tailored to the prescribing formulary that we have, the BNF, the UK BNF. And so we will need to NHSify the clinical decision support, and that will be the responsibility initially of my DNA. But how that goes long term, it's a very good question. Okay, somebody else has their hand up. Gillian.
Hi, Alex. Great talk. I was just wondering, so your clinical example was really nice, and you've got a simple genotyping test and you've got clear prescribing guidelines. But you highlighted that there are lots of other drugs that are also CYP2C19 substrates. So do you think it's appropriate to extend your prescribing guidelines to say, obviously, don't give clopidogrel and give the other stuff instead, but this may also have implications for drugs X, Y, and Z? Or do you think you would have to do additional studies for those individual drugs to have your own sort of evidence before you could make further recommendations?
Yes, that's great. So so for CYP2C19, there is good evidence for SSRIs, for example, for particularly escitalopram and citalopram, and so we will use those. So the specific guidance that comes. So if you've had your genotype done with CYP2C19, and you're not, and say you had a stroke and you went on to clopidogrel, and then you got depressed, and so we will be doing specific guidelines for those. And so every single pathway does need to be indemnified by the organization. So I think that's again why we need an override, and this relates to Nikki's question as well. We need to agree with a formulary pathway. And so one of the things I think we're not prepared as yet is to release guidelines for, say, SSRIs or PPIs, because we haven't indemnified that yet. We haven't agreed it with local prescribers and our local formulary guidelines, etc. And so what we're going to do is incrementally, Gillian, once we have clopidogrel available, then we will, well, we do already, but then we will then agree as an organization that now we're going to provide the guidance for SSRIs. But the first thing is getting that making sure that information is available, so that if someone is about to prescribe an SSRI, the decision support says, here there's genetic information available for you for this patient, because otherwise it becomes very, very difficult. That's why I highlighted this issue of information transfer and the ITC, because it's no good unless somehow the prescriber knows there's genetic information that can be used. But
yeah, absolutely. And I guess also your example was very clear because you have an alternative treatment. So you're able to say there is a genetic variation, don't use drug X, but here is your alternative drug Y. There are so many examples where you might want to advise people not to use drug X, but there isn't always necessarily a drug Y. And actually what you might want to do is just dose modify drug X. So the reporting gets really, really complicated.
Hence the need for clinical decision support, and why you need to have an overarching, and that's what MyDNA provide and specialize in. So it is complicated, and particularly for polypharmacy, and you can't get away from the need to have a decision support that takes away that complexity and makes for prescribers a very straightforward decision. And one of the things that we will need to do is say, if this, do that, so don't either increase the dose or change the drug, or don't prescribe this, so that because genetics is complicated, and there's so many variations as you've already alluded to, so we need very specific statements, and so we were very careful to do that with clopidogrel, so that no prescriber is ever left thinking, what, I don't know what the evidence is here. Am I doing something safe? Am I doing something good? That's why each pathway, every single decision support needs to be underwritten by a specialist group and by the organization to indemnify it and to say, this is what we've decided we will do with this information in this context. So it's really important. And that's why clinical decision support is so critical to the whole thing. Otherwise it becomes probably even more dangerous than before. Okay, well, no more questions coming up. I look forward to updating you in the future on how we got on. Oh, Karis is going to ask a question. Oh no, she's clapping. She's clapping. That's fine. Sorry, you had your hand up. I'll come back again and let you know how we got on with the with rolling things out across Scotland. I hope you all have a great afternoon. It's been a pleasure talking to you.